December 20th. First on the agenda is Brianna Fowler. She is the agenda.
I am.
You are.
I apologize.
No apology necessary. The suggested motion is to approve the December 20th, 2024 RRAC meeting agenda. Do I have a motion? Is
So moved. Or
there any discussion? Seeing none, we'll go to a vote. All those in favor say aye.
aye.
Same sign. Motion passes. Next on the agenda is to review and approve the minutes from March 22, 2024 and July 26, 2024. The suggested motion is to approve the RRAC meeting minutes from both of those dates. Do I have a motion?
So moved.
Support.
Is there discussion? Seeing none, all those in favor say aye.
Aye.
Same sign. Motion passes. Next on the agenda is public comment. If you are interested in providing a public comment this morning, please come to the podium. You have 3 minutes to speak. Direct all comments to the chair. No speakers this time? You want to wait to the next meeting or just sit and enjoy? All right. Next on the agenda is new business. A CMHOC quarterly report, 7/27 of 2024 through 11 of 2024. See attachment. There's no suggested motion required, but Brianna, would you like to speak about it?
Absolutely. Thank you. So it's a little bit more than a quarterly report. I think it's about 2 quarterly reports because we didn't meet in September. But that's okay. We're only required to meet at least minimally twice a year. So we've met 3 times this year. We exceed all of those expectations. So that is great. You will see that you have just some complaint information from July through November. It's been a busy few months. I've been in the rights office for 18 years. And I don't think I've ever had a month where I've had 10 complaints back to back. So 20 complaints. And I think they actually came in within like a 6-week time frame. So in addition to all the ones I had open prior, we got another 20 in 6 weeks, which is okay. It just made it a little busier. So you'll see in July, there were 10 opened. By now, all 10 of those are closed out. They are finished. You'll see that there were 2 out of the 8 in July that were substantiated. We had a dignity and respect that ended in an employment termination. So there obviously was some other things going on in addition to a recipient rights complaint. So maybe they had some other disciplinary action that was in place for attendance or documentation or something like that with their provider. And so that dignity and respect complaint, the plan of correction was that the employee was terminated. You'll also see that the other substantiated one, it was a neglect class 3 that resulted in a suspension of the staff, which is absolutely appropriate. The Michigan Mental Health Code requires disciplinary action for any abuse or neglect substantiated violations, and termination, suspension, a written reprimand is minimum. So that absolutely meets the letter of the law for that plan of correction. August, there were 10 as well that came in. There were a great deal more substantiated in August. I think there was 6 out of the 10 substantiated in August, or for August complaints. Again, the neglect class 3, so somebody failed to do that was required by law, policy, written plan of correction, or written like an IPOS, something like that, a behavior plan, a OT plan. That was substantiated. They got a suspension and some verbal counseling. We had a few disclosures of confidential information internally. All of those were substantiated and they received training and/or verbal counseling. We had a safe, sanitary, humane treatment environment that was substantiated, which resulted in verbal training or verbal counseling and training. Another neglect, which resulted in an employment termination. And then personal property limitations. So in that one, we had a provider who implemented not necessarily a house rule, but a policy for the house. And she posted it on the refrigerator and gave everybody about a month before she enforced it. And so they were limiting one of our residents' cigarettes. And she is a very good smoker.
Oh, yeah.
And they were giving her one cigarette at every shift change. And she's probably up to a 3-pack a day smoker. And they were not doing anything else to, like a patch or any other supplements to help her with any withdrawals. And this one made me a little bit nervous because I got a lot of pushback from this supervisor. So we ended up having to go to the administrator of this organization. And so she rescinded the policy. There are some things that have been put in place for the resident because she was not smoking safely. She was not disposing of her cigarette appropriately. So she was starting leaves on fire and she was starting flowers on fire, and they were a little too close to the house. So we did implement some changes in her individual plan of service to help encourage safe smoking.
Was that
So
on there at all prior to on the individual plan of service?
no, it was never brought to our attention. No,
Okay.
nope.
Yeah, so does she require one-to-one care when she goes out to smoke?
No.
No, okay.
I mean,
Why are
they should be
limiting-
watching her a
Yeah.
bit if it's that big of a concern. I feel like they were I think they were annoyed. And I think they were just taking it out on her, unfortunately.
And she's in her happy place and she's able to go out and have a
Yeah,
cigarette.
they wanted
and
her
they
to
don't
go
have
across the
to-
street and go smoke on the neighbor's property. Well, there's no receptacle there. Yeah, it was just a big thing. And so honestly, I was not going to accept anything, but let's figure this out. How can we help her smoke safely?
I'm from the era of smoke rooms. We had smoke rooms in
Yeah.
our units.
Yeah.
right, with a lighter that was in the wall.
Yep,
Yeah, and I mean, some of my patients would stay in there all day long.
absolutely.
Yeah.
I had friends
Oh,
in college who would
I
stay
did-
in those rooms.
I didn't
all
want them
day
to go in
long,
and give
so-
them their medications because it was like puff smoke would come
Yep,
out of the door.
yep.
Yeah, yeah. But that's how we discovered Wellbutrin works too,
Yep.
back in that era.
Absolutely.
So, yeah, for
Yes,
smoking cessation.
this resident has not called me since we've made any changes. So she seems to be on board and seems happy about it. So,
Good.
yeah,
Good.
yeah, it made me happy.
Can I ask you just a couple questions real quick? I was trying to see when I should interject, but some of us may not be aware of some of the work that you do. How many agencies do you oversee when we're talking? Because I want to talk about volume. As you're talking about increases in numbers,
Sure.
does it mean your volumes are going up?
I looked at that with the annual report data and they're probably about the
About the
same. So we
same.
were probably way low, and all of those busy
Better
months kind of
report.
caught us up to our normal pace.
Yeah, yeah.
But yeah, so I oversee all of the community mental health staff. And then how many contractual providers do we have?
Oh, hundreds.
A breadth of kind of the work that you're doing. So as we say, okay, there are 10 more than
Sure.
normal. Is that better reporting though, too? And kind of safety in reporting as well? Like, I feel like it won't be too punitive.
Yeah.
This is something that we need to make sure we're paying
I'd
attention
love to
to.
chalk it up to in-person training, right? I'm
Yeah,
back doing
yeah.
in-person training, and maybe that is influencing how staff are reporting. I'm showing them where the complaint form is, how to fill it out. I've been to a few programs and talked to some of the recipients of services about their rights and how to file a complaint. And so maybe that's helping.
Yeah.
But yeah, no, I mean, I have jurisdiction over all of our contractual providers. So like Dr. Brashear said, hundreds. And so we
It's
have
any-
thousands of staff.
It's
probably.
any
exactly.
service that has a Medicaid connection to it.
Okay.
So CLS providers, anybody gets paid through Medicaid,
Mhm.
Brianna has jurisdiction in our general fund programs, our state general fund programs, which are small, but
That's significant.
yeah.
Yes. Okay, that was my interjection.
Yeah,
So-
no,
Yeah.
good question. So then in September, a little bit less, there was 8, but still a couple, 3 substantiated, all appropriate outcomes, plans of correction, 6 in October, and then 4 in November. It is not uncommon to have a little bit quieter months in November and December. And then January, February, March seem to pick back up again. So I think the holidays, people's anticipation for that, which has historically been the case. So you'll notice on the October and the November complaints, you'll see blanks, right? So those came in October. So October, I have 90 days. So November, December, January is the latest that those October ones will be due. And then obviously February for the November complaints. So those are still open. Most likely, I just haven't typed them up yet.
So the other ones are closed then? They
The
don't
other
have-
ones in the months ahead, or like there's one in October that I closed out. It says 79. Oh, because I probably did it a few weeks ago or something. Yeah. And then obviously the November one, that was a no right, no jurisdiction, and that had to be issued within 5 days or less. And remember, those no code, no jurisdictions are, I may get a complaint from somebody who was at, I'll just say, Holland Hospital, right? And they'll file a complaint with me. Well, I don't have jurisdiction over anybody at Holland Hospital. I don't have jurisdiction at their behavioral health unit. I don't have jurisdiction on any of their medical units.
And that's a
So-
recent change, isn't it? Didn't-
No,
I thought we provided services. for-
we provided oversight for them. They
Oversight.
have their own rights
Recipient
department.
rights, okay.
Yes.
Yeah, we were
Yes.
providing through our board this function for them with no jurisdiction on their cases, so we switched that.
Thank you.
Yes, yes. Or, somebody will file a complaint against their sister, and their sister's not a community living support worker on her paid staff. And so I don't have jurisdiction over the sister. But if the sister was a CLS worker and she filed a complaint while the sister was working and getting Medicaid funds, then yes, I would have jurisdiction over the sister. So it can be confusing.
And complicated.
So
Yes.
just so I did have a family that did have a big issue with Holland Hospital earlier this year,
Mhm.
and they are CMH people, but all of that problem had to go back to that
Mhm.
Holland Hospital recipients' rights person.
Yes.
Nothing to do with us.
Yes. Yes.
Thank
Yep.
you.
If we had a billable Medicaid service in that hospital, we would have jurisdiction, but we don't.
For example, like if our crisis worker
Right.
did an evaluation and they had a complaint about our crisis worker, I would have jurisdiction over that
Gotcha.
crisis worker.
Good to know.
Yep. But the doctor in the ER, I would not
But the hospital would,
at the hospital. Yep.
and they should be hearing that complaint.
Uh-oh, I'm gonna have to log back in. Okay. And then incident reports are still coming in. We have a few providers that we've taught them how to do our online incident reporting because their routing of incident reports is a little less timely than I would appreciate. So we actually have a number of providers out of our catchment area, so outside of Ottawa County, that are now starting to use our online incident report form, which is amazing because all they do is type it in, hit send, and it comes directly to me. And then I can share it with the whole treatment team that's involved with that particular person, and then send them a copy back if they'd like to. So that really helps with efficiency and reporting. And, maybe there's something we all as a team need to look at, or maybe there's a rights issue that I need to that I'm questioning on the incident reports. So incident reports are coming in We generate critical incident reporting out of that. That's required by the LRE and the state of Michigan. And so there's lots of committees that look at incident reports. I think every committee that we have looks at incident reports in some way, shape, or form, whether it's related to physical management, behavioral incidents, medication reviews, hospitalizations, all of that kind of stuff, deaths. So that's been good too with the in-person training, because we also have an online incident report with the incident report, I talked about that. So that's been good because I also teach the staff who are coming through training where the incident report is, how to complete it. And then again, it comes right to me. There's no worry about saving it on your personal phone or your computer, breaching confidentiality, all of that kind of stuff. So it's been really great.
Question for you, Brianna.
Yeah.
Right now, you are the sole person handling these directly. What, do we have a backup plan? If you're on vacation, hopefully you get to take vacation. If you're ill, I know we have, the executive director is trained as an ORR agent, but do we have anyone else as backup?
We don't internally have anybody to be the backup, but if I needed anything, say I'm in Mexico on spring break, I do work on my vacations, but if I had something emergent, an abuse, a neglect, a retaliation, harassment, something like that, I have a good working relationship with everybody within our region that is also part of rights departments. And so I could call any director at any of the other regional CMHs and say, hey, I have this case, can you start this for me? And they would absolutely do that. And I would do that for them as well. So that really is our backup right now. And it has been for 15 years.
I think you bring up a good point, Mr. Byrd, because this is part of our Medicaid shortfall and some of the planning that's been stopped right now because of it, giving you some backup, because
Yeah. And it's
that's
a good
why I
idea.
wanted to bring up just how many, agencies you actually support. It's
Yeah.
pretty extraordinary.
Yeah, it is. And it's a good idea to eventually have a backup. I mean, I don't plan on being here forever. And it's a job that you really need to spend a lot of time in to learn it.
Absolutely.
I mean, you need a mentor. And I had a great mentor. I had a number of mentors. So yeah, eventually it would be great to have someone just so you can watch and learn and critique and help that person evolve into a really good rights director or officer.
Absolutely.
Yeah.
I'm thinking more than a backup, though. I feel like it should be recipients' rights department. And there should be
Right.
another person
Right.
working
Yeah.
full time
Mhm.
in my, but I had the exact same thought and comment, and just, it's more than a backup. You're not supposed to answer emails on a vacation.
Right.
That defeats the purpose. of
Exactly,
vacation, To
exactly.
get rest and respite. That's not what you're supposed to
Right.
do. So in my head, it's like it's a department of two, maybe
Mhm. It used to be.
Maybe
It used to
three.
be.
three.
Yeah.
Yeah, better safety net for sure than.
And I think one of the good things is, like, even though I do those things on vacation, I don't know, I love my job. And so
It makes it easier, but
it doesn't bother me.
Donna's accurate.
I get it.
I know,
appreciate
she's
that.
accurate.
I
You've
should,
got to
right?
just,
But yeah,
it's a vacation of the mind as well.
Yeah.
Yeah.
yeah, sure. I don't know what that looks like.
You know
So
you love it, and that's why you
I
keep
do
doing
love it. Yeah, yeah. And
At some
I always
point, you
want to be
gotta rest your
available.
head.
Yeah, yeah.
We will have to address that this fiscal year.
Mhm.
Can't wait till next.
It's a vulnerability.
Right.
And then meetings, I attend a lot of meetings. I don't even know if these are all the meetings, but it's 6 of them that I go to on a regular basis. And then after I leave here, I'm actually going to go to Byron Center, and I'm going to do a site visit today at one of our out-of-county placements that popped up the other day. Had no idea we just moved somebody in there, or somebody has been there. And one of our colleagues, or one of my rights colleagues throughout the region, they no longer have someone there. So I'm going to pop in and fill that role today. But site visits so far, so you'll have through September, or through November, 63 residential or outpatient site visits. So that could be to like a Bethany Christian Services, our ABA providers, our residential providers, our specialized residential providers. So I'm assigned just a stack of sites that I need to visit, and then we collaborate throughout the region for all of those site visits. So, and then I did Holland Hospital. I'm responsible for their annual site visit related to recipient rights, and I also do their partial hospitalization program. So
So as you prepare for additional funding, these are some of the metrics I think that are really important.
Yeah.
Yeah, to share. I mean, publicly.
Oh, yeah.
Yeah. I know I'm looking at you because I know you're both good at it, but yeah, this is really important data that I think even from a manufacturing perspective, if you're listening, it's like, wow, okay, that's a 40-hour work week, or maybe it's a 50-hour work week, but how does one person get that work done? And what are the risks, the vulnerabilities
Oh,
if we
yeah.
don't do it and do it well?
mhm.
Yeah.
Yeah.
I think too, when you added all the site visits and all of that on top of the work that you already did, that's a ton of work.
It is.
Training.
And then training.
Training,
Yeah, I wasn't doing the training, so that's 8 hours a month now for training.
Mhm.
But I love that too.
Fun, isn't it? Yeah.
Would be willing to give up, I
Yeah, so
promise.
some of the willingness to keep doing stuff, but it is the
That
role,
Job description.
it
that,
is
you
the
know,
role of this
supplementary.
particular committee to give feedback to the CEO about the resources needed for recipient rights. And for one of the functions is, and Rita used to do this a long time ago when she was on the board, do you have enough resources? She's going to say, I'm going to make do, right? But the committee can say, Dr. Brashears, please put a plan together. And I'd ask you to say that, to look at backup and appropriate infrastructure development for rights. And so the committee can actually give that directive to me to bring up before the next quarter.
So, yeah, because often it's not people, it's processes and environment and resources that weren't adequate. When you look at we call them variances in health systems. Same thing, they're incident reports, but it's like you want to immediately point to the person, but yeah, it's like taking a step back and saying, did I have adequate staffing? Did they have adequate staffing? Did they have adequate training? What was the environment? Because the environment, especially in a mental health setting, can be very dynamic at times. It can in healthcare too. So all of those things need to be looked at if we're really going to, because the ideal situation is identify the problem so we fix it so it doesn't have to happen again.
Mhm.
Yeah, and then
And
you
the-
go to people.
I know on one of his, on Dr. Bashir's, one of the position proposals is another compliance person. And so I've been chirping in Kristen's ear saying, all these incident reports that come in are really a quality improvement function. That critical
Yes.
incident reporting that I do is really a quality improvement function. So maybe your person can take at least that back.
Mhm.
And then just send me, and maybe I review the incident reports first to see if I think there's any rights, complications, things that I need to follow up on. And then I pass it to the quality improvement unit to code it and
Excellent
analyze
idea.
it. And because I'm not a data person, like I don't know how to I can do graphs if I had to, right?
Quality used to
not like-
track our incidents to
yeah.
see where we were as far
Yeah.
as the progression was concerned. Your 90-day
Absolutely.
window in order.
Who's
Yeah,
reporting, who's not reporting.
exactly.
Yeah. So
Excellent
I
idea.
have a plan for part of it, hopefully, because it really would fall into more of a compliance than recipient rights function. So,
Absolutely.
yeah.
I could
Yeah.
go on. So, yeah.
Yeah. I was just going to say,
There's so many, it's like there's opportunities. There's real opportunities.
Yeah, absolutely.
Yeah.
Absolutely.
I was going to say too, the concern is too, I mean, you're great and you love it all, but if we have to get somebody else, is it then a one-man job? Again, like you, I mean, then we're kind of looking at replacing you with maybe 4 people or,
Right.
so you don't want that out there. Like, why are we putting 4 people in now? Because she's not doing it any longer. Not everyone's going to be like you.
No, that's true.
No.
That's true. Yeah.
Oh, yeah. It'll take a long, long time.
Yep.
And I think your suggestion to offload some of the tasks to another department to assist with that is a step in the right direction, but it doesn't solve the problem of redundancy.
Yeah.
And we need another Brianna Fowler on staff,
Mhm.
thoroughly vetted, thoroughly familiar with the system and all of its nuances, so that you can step aside or, hopefully not be forced aside by illness or whatever.
I agree.
But there'd be somebody there to carry on the work with the same standards.
Yeah.
Succession planning.
Yeah.
For key positions, yeah.
It can be a very lonely job too, that
Yeah.
she has, because historically, over the years, the department in Lansing has thrown out there that recipient rights officers should not even be part of a particular CMH board, but they should be on the outside for fear of, well, it's my
Bias.
best friend that, two offices down kind of thing. And, maybe I can give her some slack you run into that kind of thing. And, staff I'm sure they're nice to you, but they tend to stay away. And, you do need some supply, apart from the workload, you need a little bit of support,
Yeah.
you know?
And that's why like the quarterly recipient rights advisory, it's not a recipient rights advisory, it's ROAM. It's the Recipient Rights Officers Association of Michigan.
Oh,
It's
nice.
a group of, from the state and local CMHs,
Peers.
rights officers. Then we get together quarterly. I don't go every quarter. But that's a great chance for all of us to collaborate and like not a lot of people understand what you're doing, except the other people
Oh,
across
yeah.
the state and my colleagues. So like Rami Postema, who's the director at MDHHS, Office of Recipient Rights, at the annual conference, we sit through all of our sessions. Her and I, we head out to the golf course and we, shoot a round of golf together. And that gives us an opportunity. I can bounce cases off of her or
Very
just
nice.
feel
yeah.
that support. And, even though I've been doing it for 18 years, there's still questions that come up. And so knowing who to reach out to, it's a really great cohesive group. Everybody's always willing to help out and listen and give feedback. Yeah, it's a nice group.
I'm thankful you have that.
Yeah, for sure. And then you'll see we're doing trainings back in person that started July 1st. Yesterday, I think I had 10 more people in a training class. There was supposed to be 17 and maybe they were all 7 were afraid of the snowstorm that was supposed to start. I don't know, but it was a great class. I've been really impressed with the staff that have been coming through training.
Good.
It is, yes, it is a breath of fresh air to see really competent staff coming through.
Anything else? Should we move on to B then, the CMHOC 2023 through 2024 RR annual report? Attachment B, suggested motion is to accept the CMHOC 2023-2024 RR annual report as presented and forward to the CMHOC Board of Directors to review with recommendation for approval. Do I have a motion?
So moved.
Support. And discussion. Hearing no discussion, or are we looking?
It's almost the identical information she just presented.
Yes.
Just for
All
the
right.
year.
So we'll just go ahead. And there are no numbers involved. So all those in favor of the suggested motion, please say aye.
Aye.
Opposed, same sign. The motion passes. And then the next is the CMHOC Recipient Rights Policy and Review Training. We kind of went over that as well. Is there anything else that you would like to share about that?
So I went through, the state provides an attachment and you have to, every rights office has to go through and make sure that our policies meet the requirements of the state's Office of Recipient Rights requirements. So the only change that I made in addition to adding Dr. Bashir's and Chief Executive Officer, hopefully I got all of those. The only change to the policy, I did make a change in policy 1.15, the consumer's right to entertainment materials, information, and news. And I will never listen to Google or whatever the word when I do the review and edit and hear their suggestions, because if you look at the policy statement, I accepted what the computer told me I should change that to,
AI.
and it does not make sense. So that should say it is the policy of CMHOC to assure consumers will not be prevented. I'm going to take out that they. Note to self. And then if you look on page 2, I eliminated letter E. Because that to me is suggesting that providers may have house rules, and that's not the case anymore. It is not the case through HCBS, even though we're different. Rights and HCBS are separate, but it's also not appropriate in the rights world anymore for anyone to have house rules. So I can say when I started in the rights office, you know, every provider had house rules. This was your meal time. This was your visitor time. This was, you know, when you need to be in your room at night, that kind of thing. No one can have those anymore. If there's an individual who needs some sort of extra guidance, extra parameters, those are to be addressed through the individual plan of service, person-centered planning process, written into the IPOS, and or maybe a behavior plan. So I took that out because I didn't want anybody thinking that they could have any sort of policy posted or house rule posted.
Sure. I can see risk in that, actually.
For sure.
Yeah.
Does the person-centered plan override the recipient right? I mean, if you set up a plan for, you know, like my son, if he was in a home and he does need some of that structure and that.
if his individual plan of service is written to not be limiting or restricting his rights,
Okay.
that's fine. But
Okay.
if there is an individual plan of service, any goals or objectives that are restricting rights, that would have to go through our behavior treatment committee to review and approve.
Okay.
But if there's a reason for health and safety of the individual, and if the guardians agree, can that not be written into the IPOS?
That is written into the IPOS. It is still reviewed by our behavior treatment committee, but it's not a behavior plan, it's a health and safety plan.
Yeah.
And so we review those also annually. So yes, like if somebody, I can think of bed rails or arm guards, you know, for health and safety, because I know we have a number of people who self-injure, and if, you know, they do it again, like helmets, all of that kind of stuff. But yes, as a committee, we still officially review them at least once a year. But yes, it can be put into the IPOS.
Now, there's a general policy that says residents in a group home will have access to food 24 hours a day.
Mhm.
What if for their health and safety,
Oh.
it's inappropriate for them? If they're in a weight management program for their health, or if they have no ability to self-regulate consumption of food, isn't it permitted to write that into the IPOS that there will be no food available except under certain circumstances?
Typically, how we first approach that is, you know, the law doesn't state what food needs to be available 24 hours a day. So we encourage providers to put out healthy snacks, fruit, applesauces, granola bars, you know, things like that. If someone cannot have access to those, well, then we would approach it through behavior plan and restrict their access to food or limit their access to food that way.
Usually has to have a doctor's order or a dietary plan attached to things like that.
Sure.
Anything that's medically necessary
Yeah.
can be put into a plan, and then the behavioral treatment process is really one of the only places we have to limit or restrict the rights.
Yep.
And, you know, in our zeal to have people have the most independence possible, sometimes it lacks common sense.
Yeah.
Like Johnny shouldn't have 25 bags of Doritos in a row, right? So this is an issue that is a delicate balance. And I'll let you know that over 60% of our folks in specialized residential right now have behavior plans, and a lot of it is for this reason. It's the only mechanism we have to use common sense for medically necessary restrictions. And it's something I'm looking into because it also drives up the cost of care to train and orient people to behavioral treatment plans or positive support plans in these settings. But, you know, in our zeal for community integration and independence, it can get kind of extreme. You know, if people want a visitor at 2 a.m. and it's unsafe,
Yeah.
you know, we have to build in some parameters. And, you know, the logic is, well, what would you do in your home? Well, first of all, in my house, I have house rules, trust me. And second, no one's coming over 2 a.m., but that's my choice, right? So it's a delicate balance of the right system, ensuring the rights of individuals being served with common sense and health and safety. And families that have loved ones at home getting CLS supports know this all too well. They balance this every single day there. So, but the rights department has to be the overseer of that. And, you know, what we're moving towards in Ottawa is like everybody's part of compliance. Everybody has a role in it. So it doesn't fall just on one individual or one division, which I'll talk about later. But common sense sometimes gets lost in the zeal to have rights, which we need, but
And I think
Can be
one
tough.
good thing, like with Rami Postema being the director at MDHHS ORR, she absolutely supports that because back in the day, any sort of limitation or restriction, whether it be for health and safety, had to be in a behavior
right.
plan. And she's really broadening that and extending some education about if it makes sense, let's put it into the IPOS with the guardian's consent, with the individual's consent, and not have so many behavior plans. Because a lot of things are health and safety versus,
In normal discipline in a
behavioral.
home, if you were living in a
Yeah.
home setting
Yeah.
too, you know, there's.
So
kind
I
of
think we're
scheduling too.
moving into
Yeah,
the right
sleep-wake cycle
direction.
when you have meals.
yeah.
Yeah.
Because real quick, that's what my point was going to be, because I've had two people that I've talked to who have kids in group homes, and that's what they're doing. They've put on weight and put on weight, and they have to go to the doctor. Then the home calls them, and they're frustrated because they keep feeding them this stuff, and then they get called. So,
yeah,
Get a
it's tough.
doctor's note.
yeah,
It-
that's
it's
why I was wondering
Put it in the
how
plan. Yeah.
A tough balance.
override that, yeah.
I have a behavior plan. My wife
Right.
says, no more cookies.
Exactly.
Then you said, stop making the cookies.
Know your rights, Tom.
That's right, Tom. You can have a cookie anytime you want.
All right. Excellent discussion. Any further questions about the policy review and training? Seeing none, we'll move into old business, and it doesn't look like we have any old business. Next up is second chance for public comment. And again, if you're interested in sharing your thoughts, please come to the podium. Good morning, Rosalie. You have 3 minutes.
Rosalie Austin, City of Holland. On the table, it says contractual or agency for the service site for complaints. Can that be like a residential site, a day program site, or identify more of the location of where these incidents are occurring and where the complaints?
I was
are
kind of
coming
wondering the
from?
same thing. Yeah.
Are they in county, out of county? And the individual plan of service, you can't stress enough how important person-centered planning is. And it's referred to as IPOS or treatment plan, but I like to refer to it as a life plan. Because if you plan your life in your plan of service, you have all these details in there. And that's basically the job description of staff, residential or in. So it's all spelled out. This is what we can do. This is how we want it. We all have the same goals and get
Everybody.
on the same page. And I thought we were gonna have a diversified recipient rights instead of the board being the committee, the board being the appeals committee. And so there's more input into these things because it might be impolite to say, but a lot of people say recipient rights internally is a conflict of interest, that it's the fox guarding the hen house, and that I'd like to see more people involved in this recipient rights. And also I like the term human rights. And yeah,
You have a lot of good suggestions.
I think we have our first volunteer.
I do too.
Yeah.
He's our advisory committee. Let's start off. Is recipient rights, I mean, that reference, is that a legal issue?
It is.
Yeah, that's what I was thinking.
But we can call it
Could be
AKA
different.
anything
We could be
want.
different.
I'm glad Brianna brought up about HCBS rules, how that is different, but is that being explained to participants that she's only in charge of the recipient rights and HPS is LRE supposed to be the watchdog for that? And then the state is the watchdog for that funding for residential. And that makes a huge difference between like, where's the customer service on the org chart? That there's a difference too. You can also do a grievance in addition or separate from a complaint.
Mhm.
That are all these complaints being explained to people? Who do you contact? Where do you contact? What opinion you want to express to who? And I like how it should be viewed as quality improvement.
The end users that give you the best information. You're an end user, right? You know. Excellent recommendations. Thank you. All right. Any other public comment? Let's look at Barbara. No? All right, then this meeting is adjourned.
Thank you. Happy holidays.
Happy holidays. Thank you. Right, and it is 9:49, and we're going to call to order the CMH Board of Directors meeting. It's Friday, December 20th. And first on the agenda is the invocation, and that is with Dr. Michael Brashears.
Okay. Father, thank you so much for the people in this room and the energy it takes to take care of all of the needs that we are charged to in Ottawa County and the CMH system, families, providers, board members. Father, even there's board members in this room that have had 6 to 8 hours of other meetings in the last couple of days, and in a context where it can be turbulent and conflictual. And I'm just thankful, Father, that as a CMH system, we're moving towards each other. We're trying to solve the problems that we need to solve. In this holiday season, we thank you for Christmas and other holidays from other faiths during this time. I ask that you allow us to have wisdom to do our job with knowledge and wisdom together so that we can meet the obligations that we have in front of us for the system. Father, I thank you for all the staff and providers that are providing the services and the countless families that on a daily basis have to balance the need for support in their own lives. And I ask that you give them energy through the season and that there's joy that's reflected in all faiths and all religions during this particular holiday season. In your name, amen.
Amen.
And next up is the Pledge of Allegiance.
I'm gonna do this, yeah.
Aye. We'll lead together. You want to go ahead?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you. All right. And next is the CMHOC mission and vision statement. Our mission is Community Mental Health of Ottawa County partners with people with mental illness, intellectual and developmental disabilities, and substance use disorder, and the broader community to improve lives and be a premier mental health agency in Michigan. The vision is Community Mental Health of Ottawa County strives to enhance quality of life for all residents. Next on the agenda is public comment. And if you are interested in giving public comment, please step forward to the podium. You have 3 minutes to share and address all comments to the chair. I guess we can do it to the board. Can we be flexible on that a little bit?
Yeah.
I think it's important. Yeah. Nope. Going once, twice, 3 times. All right. So we're going to move on then to consent items. The suggested motion is to approve by consent the following items. The agenda for the December 20th, 2024 CMH Board of Directors meeting, and then the minutes for the November 22nd, 2024 CMH Board of Directors meeting. Do I have a motion?
So moved.
Support.
Any discussion? This one, Amanda, will be a roll call vote because there are numbers that are kind of contained within our minutes. All right, so we'll move on then to a roll call vote.
Yes.
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 Yes. Motion passes. Now we are up to the Executive Director's Report by Dr. Michael Brashears. Aren't you supposed to be the Chief
CEO
Executive-
now. Yeah, we'll
CEO.
change that for next time.
Executive Officer? Yeah.
I'd still say executive director, and as I told Tom, I'm not gonna buy new
Got to get
cars.
through your cards first. Yep.
Okay, I got some items. You'll get a written report based on these comments later this afternoon. It will also be posted to the public. We did have a change in the website at CMH, and so some of our information wasn't readily available. We had members of the public reach out. We rectified it, made sure they had a packet, but I think that's been fixed, that we can post our materials. Because we did our board meeting a week earlier, we had to scramble with some of our processes to get information together. But I think we kind of pulled it off. I want to highlight some things here. The first thing is we had 2 new board members appointed by the county commission yesterday to start on the vacancies coming up next year. One was Peggy Faulkner, who was the longtime ARC of Michigan director. And another one was Robert Davis, who is a longtime social worker and clinician that's worked in Ottawa and Kent County for many years. And so I will be reaching out to them and providing more information to this group and kind of orientation to that. In January, at our board meeting, we'll review, I want to do a review during my director's report of where we all are at with people's terms and all those types of things. I'm glad to see that the board that's sitting here is intact past this month. Very happy to have our board remain with its same membership and welcome new folks in. One of the clarifications I was able to pull off with the county, which I didn't know this, we actually don't have to, by law, have a county commissioner on our board. We have to have specific population groups, family members and consumers. So once somebody's appointed to the board, if they're a commissioner or not, they can literally do their entire term. And so there are requirements, if you have county commissioners on your board, of the number you may have based on your side, 2 or more, depending on your thing. But there's actually no requirement in the mental health code for a county commissioner to be on our board. And so do I like county commissioners on our board? Of course, and the county commission appoints them. But we're trying to clean up a lot of stuff of, if there's a change in who the commissioner is, I don't want my CMH board changing. I want folks to be able, by choice, to live and go through their entire term, regardless of their status as a county commissioner. So that was something we've been looking at the last month or two to ensure we have continuity on the CMH, because we've had a lot of change there. So if you have further questions on that, as Tom's looking through the mental health code, you can call me later, but this was an exhaustive examination with legal, the board association, and they all concurred with the same thing. Now, in practicality, every CMH board in the state's going to have a county commissioner on it, because the county still has to appoint members to this board, even if they're an authority. So all the CMHs that are non-county departments, the county commissioners of those counties still appoint people to the CMH board.
Statutory requirement.
Yeah.
Too, of 10% of the general fund minimum, correct?
Yeah, well, that's on the funding. I'm getting to that coming up.
Appropriate.
But I'm just saying, in way of the public knowing that we're gonna, show in January kind of who's coming up, when that happens. I'm gonna have a discussion on that. My goal is to have continuity on the CMH board as much as we can. All terms can be 3 years. So we're gonna look at that, make sure we have that, and make sure that the appointment process goes smoother in the future. So we have 2 new members starting, and I will provide information of when and who they are when I get it. Do you have a question, John?
Oh, maybe I missed it. When do Peg and Robert start then?
It would be like in, I think it's in March.
Oh, okay.
So I have to go through and look. There's some, we're still, right. We have the pleasure on 12/6, on 6, we had an all-staff strategic planning and holiday party. It's the first time in a long time that all the CMH staff were invited to be in the same room together. We had over 160 participants. We had some board members that were able to come, thank you. And it was a good time for us to get to know each other. What struck me is that there were people that have worked for our organization for a decade that didn't know that other people even existed. And so I had them all get up by department. I forgot the access department till the end. Oh, I'll never live that down. But introduce, just to acknowledge each component of the CMH direct operated system. And I was able to review some elements of the strategic plan with them. One focusing on maintaining community and community mental health and how we're going to have a plan that does that. And Medicaid services being a center of excellence. But it was really time to get together. We had a grant that was able to pay for that. So no Medicaid dollars were used for our get together. And I was glad that we were able to do it. I don't know if those that were able to attend had any feedback on how you think it went. I know Donna was able to come.
Yeah, I just was going to say, first of all, just thank you so much. I mean, obviously, we don't see, other than a couple staff ever, so we're never going to have the luxury of meeting everybody. So I felt very, just walking into that big space and seeing all these people, I felt like I was really a part of a way bigger organization. It was really an honor and a blessing to be there. So just thank you for doing that. I really enjoyed it. Dave, we were at the same table.
Yeah.
I just felt really good. And I actually sat down to Matt Postma, and he was one of my very first mentors.
Yeah.
Who mentored for me in 2005 when I started Compassion Heart. So now he's a dad of 3.
Right.
And it was just a really cool time to be together. So I think you guys did a great job.
Yes, the Chelsea and her staff and did a great job pulling that together. We had games, we had events, we had all kinds of things we were doing. The only, next time we'll have a place that's parking. That was the only thing. We're in Holland, no one So I just wanted to highlight that, it's really important that we have many opportunities for unity and coming together. I intend to have a quarterly all-staff meeting via Zoom or whatever. And when I have them, I will invite the board to participate either through Teams or come if they would like to, when I'm addressing all of the staff. The more that they can see us as a board and leadership coming together and talking about issues together, the better we're going to be able to address the significant challenges we have over the next couple of years due to changes in Medicaid in the state. So it was we had an ugly t-shirt sweatshirt contest and a sweater thing, and it was fun. So on that. So some data I'd like to give you, since 9/30, since the beginning of this fiscal year, we've had over 122 new people enter our system to found eligible for services in either MI, DD, or family services. In my narrative report that I will send to you, I'll have a breakdown of that. You're going to get access data every board meeting from now on of how many people are entering the system. And soon, once we have the capability, you're going to see the estimated increase in expenditures or cost to serve those people. Now, if we're serving them with our directly operated staff, it's not clear how much that impacts your financial budget besides capacity and caseload. The majority of our increase in expenditures in the contractual side, with CLS and pay. So we had over 122 people eligible out of 148 people that seek services in that time period. We are letting in over 85% of people that come to CMH are getting in. Every single, like for instance, every single person that contacted us for DD services in that period of time that got past the initial screening, like, no, this is not even, got past the screening, we had 100% acceptance rate into that program. What we haven't been doing is tying the increase in demand and people entering the service and people leaving to expenditures and forecasting expenditures. And we're going to get a lot better at people understanding the impact that we are not allowed to deny people that are eligible for our services. But if the revenue is going to stay flat or go down, there's no way for us to deal with that. And in a minute, I'm going to talk more about that. In terms of crisis contacts, people that since October 1st to now, we had over 264 crisis contacts, meaning assessment for crisis services that could require inpatient hospitalization or some type of intervention. Of that, for adults, we had 170 people seek crisis services. 57 of them went into the inpatient hospital. That's over a 67% diversion rate of when people in crisis not needing inpatient hospitalization. And I'm going to talk about inpatient in a moment because you have a contract today that's linked to our plan to help stabilize some of those services. For children, we had 94 either through mobile crisis or contact with us, have a crisis assessment of them. 21 went into the hospital. That was a 78% diversion rate for folks to get in the hospital. And so is hospitalization bad? No, but we want to try to do other interventions like crisis residential or, some interventions right there or setting up appointments with providers. So we're going to get better at drilling down this information, and probably starting in February, you're going to have kind of like the CEO's dashboard connected to my report so you can keep seeing these things and what it means through the year. But we are doing a lot of work in trying to keep people in the least restrictive type of care they're in. But we are getting a lot of folks coming in the system. And folks really don't leave our system. Unfortunately, there's like 3 or 4 ways they leave. One is death, unfortunately. The other is they move. Or the other is no show. They just don't come and we can't get a hold of them. And the last category is they met all their goals and objectives in their person-centered plan. Well, when you're prioritizing services for the most severe, that last one is like a lifetime journey. So the type of service that you might get changes, but you stay connected to us in some way. So we don't have the potential of discharging the same proportion of people that seek our services on a monthly basis. So there's always going to be a growth pattern that's going up. And, you know, when we had Brianna here for rights and said we got one person here, one person there, the whole infrastructure within CMH to manage the system has been depleted over the last several years due to people leaving and not filling vacancies and other things. And so I have to come up with a plan of reorganizing some of those things so we can double up on quality and rights or fiscal services and contracts. Right now, they're kind of siloed out. So I'm going to be working on a plan to integrate some of our centralized functions like fiscal services with contracts and compliance. We're all part of compliance. Compliance is the floor of excellence, not the ceiling. So to be compliant means you're doing what you're supposed to do. We want to move to going beyond that. So we have some consolidation we have to do on James Street in terms of how our, what I call centralized services work together, because they're still somewhat siloed with unfortunately like one person in there or a person and a half. So I feel the need to come up with a greater strategy now that I've been here close to 6 months. I really see how we could benefit from that. So look for that coming up in January.
Quick question or clarification. Are you going to send all those stats that you just said to us in a report later?
Yes.
Okay.
Yeah.
And then did I hear you right when you said it's 122 new since September?
Yeah.
Let's go.
So it's in October 1.
Have qualified for eligibility.
Yeah. So think about that, 122 new cases,
Yeah.
right?
And a reduction in Medicaid funds.
Right.
too.
So our staff, when they say that their caseloads are high or you know, there's a reason, like this is what's going on.
Yeah.
But we have to solve it.
Yeah.
And this is true for most CMHs,
Oh,
Yeah.
you know.
But
So
what I
this-
want to say is I know that that's a ton of people. But
Yes.
it also tells me, if you think back to August, when you did it in service at Compassionate Heart, what was the number one thing you heard from those parents?
Access.
Why do we keep getting denied help?
And that's why we're looking at,
This is huge.
yes,
But it's also sad because that many people
yes.
in that short amount of time.
So in the second half of January into February, my Did You Know series on Friday is going to focus on access and access standards. What screening tools are we using? When does somebody go from screening to eligibility to in? To like your starting services, all the rules connected to that. Because I took that feedback seriously. So we're collecting the data to say, all right, once you get past screening, what happens then? Right? So the Did You Know series will expand to access. And right after that, based on some feedback on the public I just heard today, the next series will focus on appeals and grievances
well,
and education on that.
the no-shows, we'll align it
Yeah.
here with access too. Are you tracking by diagnosis by chance?
By population group.
Group, okay.
Yeah.
Because that's access opportunity potentially missed
Yeah.
too. But then there's also a risk component to it as well. If you do it by population, kind of, yeah, be it ID, are you saying
Sure.
like substance use disorder,
Right.
IDD and, yeah. mental
Yeah. And so one of the things we started doing over the last month or so, and it'll be done in June, is implementing a new electronic medical record and kind of infrastructure system through PCE as the vendor. They're the only, every other CMH uses this system and all of the regions use this system. It's going to help us with data reporting in a more efficient way, forecasting models. And more importantly, it's going to help us with all of our staff learning a common language in our EMR. We've lost a lot of knowledge of the current system we have with people leaving. So we had a naming contest because PCE doesn't want to be called PCE everywhere. So each CMH gets to pick their name. And the winner was Otto, OTTO. So when you hear us talking about the Otto system, that's the thing we're implementing that will be in June, that will have a lot more continuity in our data, our forecasting, our budgeting. There are literally things that our new system will do that we have folks in fiscal services and other places doing double data entry now. and manual lookup of like, say, secondary insurances and things like that, that we'll be able to do with a push of a button.
Do you have a scheduling component?
Oh, yeah, the whole
Okay,
thing.
that's why,
It's the
yeah, as we're talking-
Scheduling, the
That's your
the
data collection.
education to folks, the whole thing is changing. And so we're going through a systems change at this point that's going to go through June, that's going to really help us with understanding our Medicaid funding and forecasting better, some efficiencies that we need now. And I haven't been able to sit in a lot of the meetings, but the feet that are, because we have a whole way we're doing it, but the vendor says that they are very impressed with the level of commitment and dedication that our staff are doing in this. They're not getting people that are going, oh, this is too big right now. They're all eager. You mean it can do this? It can do that? Wow. And so who knew that putting in a new EMR system would be a unifying factor for CMH?
It's never been the case
Usually
before.
isn't, yeah.
Not in the medical
Right?
field.
So, but we look for, it's going well, but that's part of our strategy to get more efficient in CMH and have better data and be able to demonstrate one simple thing that I want. Does what we do matter and does it work? So our whole outcome platform can be redeveloped. So we're going through that, and you'll get updates on how that's going on there. But I tell you, it's one of those things where it's a heavy lift, but it's needed to help us solve some problems. You'll notice today in your packet, there are some contracts that are amendments focused on buying beds at Holland Hospital and buying beds, like all of them, at Robert Brown, our crisis residential. This is part of our strategy to deal with our Medicaid deficit reduction. We want to ensure that our inpatient options to keep deferring more are available. And so Holland Hospital, and this is in the contract, is literally going to give Ottawa County CMH the right and exclusivity to 4 of their beds that are usually always full over there for psychiatric inpatient, and they have the lowest inpatient rate of any of the hospitals we have. So Michelle, our director of MI services and Holland Hospital, brought this to our attention, and we're going to get unique exclusivity in using those, so folks are not sitting in the ER at Holland Hospital if they need admissions. I'm looking at the exact people that know what I'm talking about, because in the past, we're competing with everybody else for those beds. We're getting exclusive rights to those beds at a rate that's less than any other contract. And we're combining that with doing the same thing at Robert Brown, which is a crisis residential program that instead of going to the hospital, you can go there for up to 14 days. They have to be renewed every 3 to 7 days. And that's $300 less a day than the hospital. So buying capacity with exclusivity rights and using that is going to help us reduce some of our expenditures in the inpatient line.
Do we have to pay for those if
Yeah.
they're vacant?
Yes, we do. I'm not anticipating a lot of vacancies. However, we will have monthly and quarterly analysis on the vacancy rate. At Robert Brown, other CMHs can buy that from us. At Holland Hospital, we didn't want that option because because it could be a Friday and I have someone being assessed and they're like, okay, we have a bed, and then there's an empty bed in Allegan or somebody else needs to use it that night. And then Saturday, if I need that bed, it's full. I didn't want that. We have enough utilization for inpatient where I'm convinced that they will be our provider of first choice. They work well with our folks. And I'm not anticipating a large degree of paying for beds that are empty.
You're going to reduce costs in the emergency room too.
Yeah.
That's where your highest cost is. The longer your length of stay is there, the higher your costs will be.
The
So I-
idea is
For admission is.
linking crisis residential with exclusive inpatient beds in a cost-effective way instead of sending people out of the county for hospitalization. In fact, when we have somebody out of the county in an ER, say there's an open bed at Holland right now, it's very rare they're able to transfer them. We've been able to get an agreement with that won't be the case. If somebody shows up at like a ER in Grand Rapids and they're one of ours and they live here and there's an open bed in Holland, we can now facilitate a transfer to that, which is a significant cost savings for us, but it's really aligning the crisis level with our teams and our providers here. So later on, you'll see a contract for that, and I wanted to link it to our Medicaid deficit reduction plan focused on looking at inpatient expenditures. We have consolidated and shored up our system, which I believe we should see within 6 months a cost reduction overall in our inpatient expenditures, because we're paying $1,200 a day or more in other hospitals. This is $9. And we can step them down right into Robert Brown Crisis Center, decrease the length of stay, but move them there, and that's $600. So there's a saving of close to $600 a day if we use our savings right. And so we aggressively pursued this. Michelle Vanscal, who runs our MI division, I tell you, she got on this with Holland Hospital, and it was a nice Christmas surprise that we were able to do this now while we're dealing with this Medicaid kind of issue.
So I've never been on that unit. How many beds do they have?
We have, are there 6 or 4 beds? I always forget. I think there's 6 beds at Holland Hospital. Yeah, I think there's 6, and we got
The whole
4.
unit is 6 beds?
Yeah, it's not big.
Wow, okay, so are they all like right next to each other?
Yeah. They have a whole new, we can take a tour if you want to go, because they just revamped the whole thing.
Well, what we can run into sometimes is they'll say this person's too agitated for us to place them in our facility because they'll tip over the milieu,
Yeah.
so to speak, and I don't know.
Yeah, we had that discussion with them and in ways.
Leverage there.
Oh, yeah.
Okay.
Yeah. If they deny one of our admissions, we're setting up a whole process of what the denial is and why it was.
Okay.
It can't be just on the preference of the charge nurse.
Okay.
Okay.
I was gonna say, we
Yeah.
were never allowed to do that.
Yeah.
Yeah.
So I bring that up because it's part of our deficit reduction strategy. We're still figuring out what our projected Medicaid deficit will be from last year. Those numbers get finalized, and we really won't know until February where we landed last year totally. And in this year, we're still working on our projection models. And one of the things I've been doing is we've been meeting with the regional entity to talk about Medicaid revenue. And we had a first meeting yesterday to understand how the revenue is being distributed by the region, and we're setting up other meetings to make sure that we're capturing all of the revenue that we can. And we know the best way to advocate for more Medicaid. And we're doing that in partnership with the Lakeshore Regional Entity. And they've been very supportive and helpful on that. The fact of the matter is that Ottawa County, we've had a decrease in Medicaid revenue because our number of enrollments in Medicaid has gone down. So as the number of Medicaid enrollments go down in Ottawa County, they're off Medicaid because it's going back to pre-COVID standards, we actually lose revenue because we get paid per Medicaid eligible per month. We get a payment for each person that's enrolled in Medicaid. So I've asked the question, and it's not popular to ask, what are the expectations of the region and the state when your revenue is going down, but your activity is going up and you're required to serve them? Are they in essence in breach of contract of not giving us enough Medicaid revenue to serve the Medicaid need? And so we're going to have to tally and get really good at understanding our costs for every Medicaid service we do, that we're not leaving encounters on the table, like reporting what we're doing, so that I can answer that question no later than the end of February. And the question is, do we receive an actual fair amount of Medicaid to meet the obligation? And I can't answer it fully yet. And I'm doing it in partnership with the region who supplies us the Medicaid, in partnering and answering that question. And they've been very helpful in saying, yes, let's answer that. Because you can't just cut Medicaid expenditures. You can't just go, all right, we're going to downsize the CMH staff who are doing Medicaid services when you have a growth of 122 people a quarter almost, right? And they're growing. So in my budget deficit plan, once we know the final Medicaid deficit for this year, I do not have staff elimination in it, Medicaid staff to be eliminated. It's my belief we don't even have the full capacity to deal with the incoming folks. But I have frozen 14 positions. Some are vacant and not new positions. Some are new positions. I have frozen filling them until I get an understanding of the true Medicaid deficit number and the other levers that we're using to balance it. So we are using fiscal responsibility to freeze positions. But I have developed a process to say if there's a vacant position and it's vital for the, like, it's the one rights person, say that was open. Well, you got to fill that. So I have a process of analysis of can we keep that position open or not unfilled for 90 days, or do we need to do it now? And staff have to send that. There's a process we use, and I have to make that determination. At the last meeting, I asked this board if it would be okay if I inquired with the county if the county could use county general fund to deal with expenditures from the county, pay increases for county employees. So in that vein, I set a series of discussions with the county administrator. I also copied fiscal services and key folks to answer the question, can the county use county general fund to pay for CMH Medicaid kind of services? And at first, there was some thought that you couldn't do that. It's been clarified that the county can indeed give us more than the 10% match that they give us with general fund every year if they so choose. So it's not illegal, and the county does have the availability if they choose to increase the amount of money they give its department to cover cost if they so choose. So far, the feedback that I've gotten from the county is we may consider it as a last resort, but we want you to use every other CMH funding source besides Medicaid, and that would be millage and CMH general fund, not county general fund, before we entertain an increase in the general fund allocation to the department. So what I needed was an answer so that I could then plan how to solve it. And I'm going to use that methodology. I'm going to use, once we understand the true deficit we have, what other funding sources to a limit can we use before we ask the county to consider giving more? That could be more revenue from the region. That could be some use of millage to cover some of this. That could be if we find near the end of the fiscal year coming up that we have excess state general fund, which we never really do, but you could have it. Some years we had a little bit. So we're being asked to be stewards of our budget, including county expenditures that are not in my control, by the way, how they're allocated and the amounts of them at all, including staffing wages for employees, to use all of our funding sources first. So what I'm going to do in that vein is come up with an impact analysis once I have a tangible number. If it's like a $3 million, I think we're on $3.2 million projected Medicaid deficit, how we would do it in that way. But my plan will not include cuts to Medicaid direct providers of service in our organization or cuts to provider rates. It only compounds the problem. The truth is we need more Medicaid revenue, better utilization management strategies, which we're putting together, to deal with the Medicaid problem. And for years, we were using millage to help stabilize residential providers. We've spent over $12 million over the last several years for a service, I think, that should be 100% stabilized with Medicaid. And because we used millage all those years and other funding sources, we never increased the rates for our providers. And I'm talking all providers, like CLS and non-residential, like all of them. And we've kept them relatively flat. And the problem with that is that the region, the state, really didn't know how expensive or what our Medicaid expense needs were. So we weren't reporting like, you know what, we need to actually give the providers a 5% increase. That means the Medicaid budget should go up like this, because we were told we have to stay in our Medicaid budget no matter what it is. I fundamentally disagree with that philosophy with the, because We stay in our budget, yes, but if we don't have a way of informing the region, the state, what our true Medicaid costs should be, and we can prove it, they never know it's a problem. So we've been using local dollars to supplement the lack of Medicaid coming into our county. And we've been doing a good job over the years being a steward doing that. But as Amy says, it's like landing a plane on the runway with all the funding sources. And I'm like, yeah, let's not hit a mountain, okay? As we're trying to land the plane of how we balance our budget. And so I'm just letting the board know that I intend to keep working with the county with the directive I've been getting. Right now, there's not a county administrator after January 1st. I'm sure there'll be one appointed, I hope. I don't know if we have an HR director in the county or not. I heard that somebody was hired, but I haven't seen an announcement. And so I'm working with a county structure that's in flux, to say the least. So some of the answers to my questions will have to wait until there's an actual administrator in office, an actual HR director to deal with that. And I know county commissioners that spent 6 hours yesterday wrestling with these issues know exactly what I'm talking about. But that does hamper our ability. Our staff were supposed to get a 4% increase in January 1. I haven't blocked that. And so if I don't address the provider issue at the same time coming up, then all we're doing is increasing expenditures for directly operating the CMH staff and then leaving providers in the cold. So I have to put together a budget to propose that may make our deficit look even bigger, because we're not paying the appropriate rates and we're not having enough options. And I'm almost done with my report because I said I wouldn't take forever today. We have families that we give CLS, like, hey, go find your own CLS people. Respite, go find your own respite people. We don't have a comprehensive system to assist families with the provider network that we've developed to give them options for. So they're often scrambling to find CLS providers, respite providers, and other providers on their own. Well, we need to develop that network and understand the true cost of it. So the good news is it's all fixable. We can all move in the positive direction to both understand what our true Medicaid cost is, what the role of the county is, and that's good news. We have major opportunities to strengthen where we're going, but you're going to get some information that at first may look shocking. The actual cost that we should be providing providers and families to find CLS is really this when we do appropriate procurement standards. So you'll start seeing that. And so I often send information out and it's like, okay, here's another thing that brochures are sending out. So I'll be more succinct in it, but I want you to understand that we're just beginning to understand the true Medicaid need in Ottawa County. We're not at the end of the journey, we're at the beginning. And I'm actually thankful in a way that we had an unanticipated increase in utilization that caused a deficit. Because now it's having us examine, how do we know that in the future, what's truly needed? And I don't think we truly know the full Medicaid rate need to assist families. But I'll tell you one thing, we're going to find out. So if you get worse news, we'll always have a plan to solve it. Our job is to solve the problem. They are all solvable in one way or another. But I'm not recommending CMH cuts to people that directly provide the Medicaid services because I don't have enough of them to do it in the first place. So why would I do that? Yeah, let's have 4 less case managers with more people coming in. I have some examples where some folks haven't heard from the case manager in months. We got to rectify that now.
Your minimum's monthly, correct?
Yes.
Yeah.
So in conclusion of that, I'm using several strategies to deal with our budget situation. How to increase revenue, how to get more efficient in understanding the problem, what packages do we authorize initially, and how we make those determinations. So in January, there's a lot of heavy lifting in those regards. So our January board report will be filled with how we're doing on that with more accurate numbers.
Michael,
Yes.
if I could interject here.
please.
I think you've accurately identified the issues and the various components of them. Working with the county on financial rescue is the last resort.
Correct.
But it's a small contribution to the overall problem. The magnitude of the problem lies with Medicaid funding equity.
Correct.
Is the Headley amendment still applicable to Medicaid funding? Because for those who are not familiar with it, the Headley amendment said that the state cannot impose an obligation on a unit of government without providing appropriate funding to cover the costs. And it seems to me that that's the root argument on Medicaid. We have an obligation to provide services to those who are entitled to them.
Yep.
And the state has an obligation to provide adequate funding for that. And I think there's no question that they have not done that, at least in the current state. So if that's the root issue, that's going to solve 90% of our funding problem if we get Medicaid.
Yeah, it would. What's being done is it's being dealt with in the guise of managed care. So what the state would say is that we're giving the appropriate amount to the region to manage. So they're saying you have enough money based on how they calculate what we get per region in the Medicaid. My job is to become extremely knowledgeable on that formula to make sure that we're giving the state all of the appropriate information to determine the true cost and need of the region. And so Ottawa CMH has to become a leader within the next 6 months of understanding how that's done and giving the region and the state adequate information on cost and the level of need that I think that our new system we're putting in is going to help. But we have been lagging behind in our ability to do that through many variables within Ottawa. So, Tom, I would say that it's being dealt with through this managed care. I call it the managed care illusion. It's only managed care if the amount of revenue in the first place is sufficient to do it. I can manage something that's reasonable. But in terms of the county, it is right now a process of last resort. But I will tell you, I've been going to county meetings, the last couple of them. There seems to be funding somewhere. So I'm not going to ask for another allocation to the department unless it's absolutely vital. But this board charged me to go ask the question, and I did. And the answer is the county at any time can give more than 10% if it so chooses to its department for whatever reason. And some counties do. Now, I'm not saying Ottawa County has to, and we're going to go through last resort, but I don't intend to do this cut on the backs of Medicaid recipients. I will not do it. So if that means I have to resign in 11 months because there's no aid coming in, I am not cutting services that I'm not allowed to cut, and I can't cut the service network for Medicaid because it's underdeveloped in the first place. So we will get creative in solving this through efficiencies and other things and more revenue and other funding sources. But I'm just letting the board know it's my position as the CEO that we cannot cut provider rates and we cannot cut Medicaid directly operated services within CMH and maintain our obligation. So I have to get pretty creative, which I will.
And so informing the state
Yes.
needs to be a priority. So like the actual consumer needs and acuity system, we have something like that. You said
Yep.
that we are not using to our capacity.
Right. We have to be better at it.
Accurate? Yeah. So that will be helpful. And then our millage and the way that we've used the millage, although be it kindly, has somewhat masked the actual cost.
Yes, we
For
have filled
services.
in the gap, which was an original reason why we got the millage in the first place, because we were anticipating several years of Medicaid decreases, and we're like, what are we going to do? Well, the millage came up, and that's been helping.
See, and if I'm sitting at the state trying to make these decisions as far as how much I'm going to fund Ottawa County, I'd look at you and think you're best practice because your rates are low.
Yeah,
comparatively.
well, not only that, they would say, gee, look at the local commitment. Ottawa County has done a great local
Oh,
commitment to
we-
CMH through the millage.
But-
So you know,
It's so dependent upon the voter though, too. So the
Right.
millage, I mean, the millage is kind of, I think at the time, if I remember correctly, politically speaking, in 2016, can do kind of right around that period.
Sure.
And I think the people were thinking more along the lines of, we've supported this organization for the years and has provided a wealth of jobs even, in our community or employees. But, again, the millage dollars weren't meant to necessarily take care of CLS needs or residential things that Medicaid actually funds.
Yeah.
Right?
So,
So we're going to be cleaner about kind of.
right, it's really understanding what our true need and cost and being unafraid to say, listen, I can't ask fiscal services, oh, by the way, add $7 million to our deficit because we're going to give all these increases to providers. But I have to collect that information, let the region know this is what's needed. And this is what's needed to, has to happen at a minimum by the beginning of the next fiscal year. Because if not, we are going to have not just residential providers, we have families that can't find CLS workers because we can't pay them enough. So the whole thing is an ecosystem that has to be looked at. So this will be the year where we truly understand the cost of care and the appropriate requests for Medicaid for that. Now, speaking of millage, we did put out a second RFP for a small portion of our millage savings that we had from last year. We got 27 proposals of some of the most innovative uses of millage dollars, from housing assistance to, just way to enhance some outpatient services and that we'll be looking at. So it's like, Michael, on one end, you're saying you don't have Medicaid to do that, but in the other, we have some millage we're using to be more creative outside of Medicaid, because I don't want Ottawa County just to be a Medicaid health plan.
Can I interject? Because I
Yeah.
just want, it's like, what's your priority though? Like, as we're looking at this, because it feels like to me, nurse, RN, worked in the emergency room for years. It's kind of a 911 in a sense
Right.
that the state needs to know the actual
Yeah.
cost of
Yes.
care here, cost of
Right.
service here.
That's
Um,
priority one.
Priority one, and we've got to do it like within this fiscal year, or we're
Right.
going to end up with that deficit. Because yes, the funds that you're talking about for the board, those were funds that were left over from
Right.
ARPA dollars that got moved into a board initiatives fund.
Oh, you're talking at the county level, yeah.
But when you were referring to,
Yeah.
there are
Oh,
some
yeah, yeah.
dollars there, but yeah, it was a limited amount. It certainly wasn't the 57 million that they started with. We had approximately 5 million in place. So again, that's a temporary rescue and it's not a long-term strategy. That's why I keep pointing back to the state.
Yeah, my intention
Cost
is
of
only to
service.
go to the county and ask for additional allocation as a last resort. And I got to figure out what that
And you
means.
get minimum, CMH,
Yeah.
it's a minimum allocation by statute, only 10%. I
Right.
mean, they could do something more.
Yeah,
Yep.
but this CEO doesn't actually get to set the level of compensation for the county employees. I can give feedback, but ultimately the Board of Commissioners vote on the COLA for all employees through the administrator's office. Now, we're in feedback, we work with them, but I don't feel I have the authority to say, you're not doing that, or it should be more or less. And so I'm working out those issues. So once we get a county administrator, and we'll go through that. But the bulk amount of our expenditures for our employees are not in my control.
So are you, as far as like you've right now frozen 14 positions, and how would you prioritize like release of those positions? What are your
If they're vital
priority
for
positions?
operations for a Medicaid service, right? Or it would put consumers at risk if we don't fill it. I have 4 questions. I'll send them to the board that we look at. Now, I get all kinds of responsibility of how to solve the problem. I'm the one that has to solve the problem as the county department head, freeze positions, choose which ones, all that. So aligning the ability to have control on the front end and the back end would be nice. And I'm working through that with the county. And I'm confident we'll come up with an arrangement that I can work comfortably within a county structure. But, I want to move towards the county. I want the county to invest more in the CMH department, not less. Because if it's flat or less, then why are we a county department? I don't understand the reasoning at that point. If they can't come in at the end of the day and help, and they're just expecting me to gut the system, well, then that's when I have to have a different conversation with this
You're
board.
obviously too lean.
Yeah, so it's like, well, all right, if the only way to solve a deficit within our department is to cut our funding sources only, our people only, if I can't get other revenue in, then it doesn't feel like we're moving towards the county at all. And I like being a county department, and people don't believe me when I say that. But I do. I think there are huge advantages of coordinating with the sheriff department and jails and other departments. We have a luxury. But I am not going to cut on the backs of Medicaid clients when I don't have to. So I have to have that stance, or it's going to be like 2016 all over again. We cut all these positions. We're gutted, and it's taken 10 years to build back.
And you haven't completely built back.
No, we have twice as many people we're serving with 3 times the budget with less people than when I was here last. So like, I
How
don't
do
know.
we help you? I'm so thrilled that the EMR is going in place because that's going to help you with the data to support.
The best way to board for this
Sure,
help,
for the state.
to help me is if I'm going in a wrong direction, to let me know and to ask questions. And when I send more data out, but I feel the total support, by the way, of most people in the county, in this board, county commissioners, we've never had to ask the question in this way before. What does it mean to be a county department? So anyways, that was the end of my report, but I'll take questions.
Commissioner Rhodey?
Yep. It's a couple of questions. One, are we seeing the state take some of that mental health funding and putting it towards mental health services in schools? Is that part of what's happening?
Yeah, there's been a shift.
Okay. And that doesn't really help because the need is still under CMH.
And it also helps the schools identify more people to send to us.
That's true. That's true. Yeah. Okay.
It's not a comprehensive treatment model there. It's like, oh, go here.
Yeah. It's because it really seems like we need to have some bigger conversations on the state level
Yes.
because the counties, the county's funds, while there can be some stepping in to help, like even county revenues have been, this past year, they were shrinking.
Yeah.
They weren't going up as much as expected. And so I think we really need to hit the state level with it and talk to them about the shift that we're seeing towards the school funding.
bet.
And so along those lines, would you want to start those conversations now?
Yeah, we already got an advocacy plan being developed. We actually had an appointment set up for the county as a kind of lobbyist. We're going to
Yep.
get that going.
Okay.
But I want to do it with a group of folks with the same group of CMHs with the same issue I'm having.
Okay.
And, there'll be advocacy updates I'll send to the board that the board association, our trade association, has been doing to fight this issue of revenue and to advocate for it and to spell out the problem. For us in Ottawa, I just don't know if we have been able to adequately say, here's what the need is.
Right.
Because we've just been surviving and solving things and doing things in a high quality in a lot of innovative ways. But on the Medicaid side, which is the bulk of it, we've been kind of like, well, we're working with what we have and doing the best we can. That's why you have all kinds of grants and you have all kinds of millage stuff going on in our county, which other counties don't have, which
I'm
thankful for that.
glad that you're working on the metrics and the data so that you can have something to bring them, so they can have something to work with. So what's your timeline on that? Are you saying February?
Yeah, like I have to have a working model of understanding our true need by February.
Okay.
Like, and then populating it and getting vetted. And I'm having the regional entity do it with me.
Okay.
Because if they don't agree with what I'm coming at, then my own region ends up fighting against me. So we're going to have them help us determine some of these things. And they've agreed. I copied you all an official request for their assistance. And they have said, yes, we'll send people. And because they have data sets that we don't have right now to help us do that, or we can't get to for various reasons. So I have to have a working model by the 1st of February. The advocacy at the state in terms of more revenue has to begin as soon as possible,
Yes.
but adding more elements to it. Because everybody says I need more money.
Right.
I have to demonstrate how it's unfair, how there's not equity and how this is being done.
And I think it's a really great opportunity. It's awful, but it's a great opportunity that Kent is struggling so much.
Oh,
too,
yeah.
Because you have two pretty strategic, you know, counties that really need help.
Yeah.
So,
Yeah, and I have a meeting with their director Monday at 10 a.m. to talk about this.
okay.
So there's a lot going on, a lot of good things, but we're in information gathering and stabilization. We did freeze positions. We did some other measures to like freeze frame to figure out what's going on.
You have a
with it.
couple of positions that are revenue generating though too, correct?
Yeah, if they generate a revenue outside of Medicaid, we're filling those.
Okay, good. Yeah.
So what we're trying to do is say, let's just hold off on some of our booked expenditures until we know where we're at. And then kind of release things slowly. Because when we asked for these positions in the past, it was under the belief that we had a Medicaid dollars to fund it. So when you don't, you have to kind of take measures.
Can I just say something? Because I live in the world of autism, right?
Right.
I live in it realistically with my son and every day. And so the financial piece of this hurts my heart so bad.
Mm.
But I do live in these trenches, and when these supports coordinators and sales workers fall apart,
Right.
guys, our families fall apart. And
Right.
I had a mom email me the other day. Her daughter's autism and anxiety is so high because of the supports coordinator change. So when these things happen, like it is really real in the trenches. And it's horrible what the families are trying to go through. And so whatever we got to do to figure this out, we have to, because the families are the ones who are seriously suffering for the lack of support that we have to give to them. And so it is a big deal, but it's a really big deal when you're seeing the fallout of the lack of that. Even that little change in that person who sees her, it changes. And now she's in her autism, right? If you don't with autism, you can't change things. They need consistency. They need the sameness all the time. My son struggles with, why do we change that? I'm like, so you try to have an explanation, and they can't just adapt to that. So it's a huge, huge ripple effect.
Impact.
And one other thing kind of along those lines too, Donna, is that there are a lot of families who are providing for autistic children and children with, you know, other similar type needs who aren't on Medicaid. And so,
Same here.
right. And so I'm like, these are huge expenses to families,
Yeah.
you know, who we aren't even serving here.
Yep.
And so I think even on a state level, there should be some conversations about,
Yes.
you know, our families are really burdened with,
Yep.
with these needs. So.
Mr. Byrd.
Michael, lost my train of thought here. Our provider rates.
Mhm.
We know that they are not adequate to serve the cost of providing service. I'm familiar with a provider who was sharing some data. They have residents from 5 different counties. Our reimbursement rate is the lowest of all of those 5 counties.
Mhm.
And, you know, my off-the-cuff comment to them was, well, if I was on your board of directors, I wouldn't accept any more consumers from Ottawa County. If you have an opening, get one from Allegan, get one from Jackson, who is paying more to cover more of your costs.
Yep.
Do we have data that shows our costs for services to providers compared to the rest of the state? Now, I realize that the difficulty is comparing apples with apples.
There used to be a report that doesn't exist anymore that does that.
Mhm.
That has to be resurrected at the state level. But that's a great question. So like, you know, we have provider rates in specialized residential. If you don't include the millage, we are the lowest. So when you were looking at that table, it didn't include the amount of millage payments
Right.
on top of Medicaid. So if you just look at Medicaid rates for specialized providers, we're near the bottom in our region in what we pay. But we've been supplementing that with stabilization with millage, because there hasn't been adequate Medicaid to increase the rates that stayed relatively flat. And so, yes, that's the problem.
That shouldn't matter with regard to the state.
Mhm.
You know, if
Yeah, they don't
we're
care.
paying $100 to a provider for this service and someone else in the state is paying $150 to their provider
Right.
for that same service,
Right.
who cares what we're doing with the millage? that's out of our pockets.
That's
Out
right.
of our generosity to the system.
But do you see it masks the problem? It hides the problem though.
Yeah,
We've had to use millage because we haven't increased our Medicaid rates and had sufficient Medicaid to do that. I'm no longer willing to do that with the exception of keeping people open. Literally, if we didn't use the $12 million, we would have had at least 60 or 70 vacancies of people not being able to remain in their
Yeah.
homes. Like I literally was at Harbor House Ministries board meeting 2 weeks ago. If they don't get an increase in their rates by next fiscal year, they have no choice because they can't fundraise at all to start saying, we can't do this anymore. And I believe them. But it's the same in all of our rate structure. It's not just specialized residential. We got families that are trying to hire CLS workers and we don't know what we're doing. Like, so it's a fundamental problem that we will have the ability to identify and solve. And thank goodness we have some local millage to help us get through. But this is why this is the year of reckoning, put it that way. It comes to a head now.
I really hate to say it, but I think that's what's been stirring in my heart for probably a couple years as well. It's good that we have that millage for the things, but I think what you just said, Michael, is it's kind of masked the problem.
Right.
And we haven't taken the real look at like what the problem is. And so it's a good, but it's a bad.
Yeah, we didn't have if I would have been here the last couple of years, we'd be in the same spot now in the same way, because it's really, the philosophy has to change about adequate Medicaid funding. And it's really working with the region, the state to say, well, what do we need in Ottawa County? And then someone say, that's too much. You can't have that. And well, how would you manage it? Right. But as Tom knows, I signed the contract with the region and I'm saying I can perform all of these tasks with the money I'm given. So the next time the contract comes up, I'm like, well, should I sign it? You're giving me this much Medicaid. I can't actually do it. That's what our providers have been in though. I guess I'll sign it. I'll get something and we'll deal with it afterwards.
What about the other CEOs of the CMHs and the LRE? I mean, if
Same-
you all,
same-
if you
yeah.
can still, you all say not signing.
Yeah, we all signed our current contract, but yeah, but I guess what I'm saying is we have to get clear on what our true cost of care is. We're not there yet in Ottawa. Once we do that, we can really advocate where we need, once we know and we're confident, you watch us take off and trying to figure this out.
was the region not originally charged with the responsibility to unify rates and services throughout the LRE?
The region could do that if it chooses. It delegates it to each of the CMHs.
But they were originally charged by the
Yeah,
state. for
they are
doing
actually
that.
the ones responsible to ensure the provider network. It's a delegated function to each of the CMH partners. There are some regions in the state where they do all of that, where they set the rates for the entire region for the majority of services. Now, I'm not saying it's the correct rate, but the models in which it's modeled regionally can vary from region to region. We've had a strong delegation model where our regional entity really says, here's your money, manage it. I mean, a lot of protections. I don't want to oversimplify it, but the region isn't setting the rates, setting, how you do that part of it. They would have to be tripled in size to be able to do that. So some of it is the way we're structured. And as I get to know that, I can make recommended changes to that process. That's why I've asked them to join us at the local level in figuring this out, because it should be regionally applicable.
Yeah.
And so our thing is, if we can't all come together, region, come to us. And that way our system's being development with the complete observation and approval of the region. So I don't go through a whole process and they go, why did you do that, Mike? How did you come up with that rate? So they're going to be sitting alongside of me the whole journey. And then if it's applicable to the region, they can declare that. If not, at least my model will be approved as a management model. And I've told them nothing about us without them. And they're going to dedicate staff to work with us and do that. And, Dave, you've been at those regional entity meetings. We're going to be pro-region working with us for a state advocacy approach that does, I don't need conflict in my own region. If I go to the state and it's against, it's just silly. So they're going to be working with us. We're going to work with the region. And if the region decides to make that applicable through the region, that's fine. But I'm not going to force that issue. In Ottawa, we're moving towards excellence with them standing beside us, just like the county beside us.
Robust conversation.
Yeah.
Yeah. Well, please, yeah. I'm sure we'll continue to get more information from you and let us know how we can be helpful.
I will.
So next is item number 8, which is presentation.
Don't have any.
Don't have any. All right. And then next on the agenda is number 9, old business, Keys to Happiness Counseling Contract with Dr. Michael Brashears.
Yeah, so that's on one of our contract amendments. This one has been on our table for several months as I verify certain elements. What I've been able to determine is Key to Happiness. They have contract providers within them, but Keys to Happiness, which is one person, it's Sandy, who works at the LRE as well. We had to work through, is there a conflict of interest? And there isn't. She provides her electronic medical record, her space, and billing for contract providers in her office. And so before, I thought it was just contract providers using her office, and I was pursuing the approach of having individual contracts with each of those providers. And really getting an understanding of the model, it actually can be appropriate to have a contract to Keys to Happiness in general. We've credentialed all of their providers. They meet our minimum standards and quality standards. All of the providers have to use family-centered planning when they're serving children. And when you get to the contract, we're expecting about 10 to 15 cases coming in. None of our children's services contracts, and I want the board to understand this, can keep a family out of how treatment is done, what's being discussed, what are the plans and treatment plans and person-centered plans. To be a CMH contractor for children's services, adolescent services, you must, not may, use family-centered planning. So all of the person-centered planning and discussions are with the entire family, even if that adolescent is getting counseling in between them. So we don't have a system that just sends adolescent and children to clinicians and keep the family out of it. That's not our system. So there isn't drop them off. I hope it goes well. Yeah, see, even that, right? That's Bill's meter that said, Mike, stop talking. But like so I'm bringing this back to its original contractual safe, but the original contract with them, geographically centered services will take place in the Coopersville area, either directly or remotely, but it's there. In the context of family center, all of the providers were actually previous employees here, other therapists that worked here for years that are here. They have been vetted. We've spent 3 to 4 months to ensure we can move forward. And the original issue was, is this a conflict of interest? Because Sandy works for the region as the clinical director. She's not providing any clinical services, just oversight of the billing that comes through, the use of an EMR and the office. She's in our contract, she can't be the direct provider with me feeling comfortable for a conflict of interest. Even the region said, yeah, we'd rather have her not do that. But having a practice that manages that, we're okay with. But I wanted to ensure the board that in any contract we have, this one and others, with adolescents and children, it's all family-centered planning that includes the guardian and family every step of the way in the process. And I had, and that wasn't necessarily the issue with this particular thing, but it has been an issue in the past. It's like, what really happens? Like, is it family informed, or are we sending children and adolescents to providers that just can do whatever they want, right? And so we actually have, and if a board member wants, I can send you our policy on family-centered planning. It's our contractual language. It has to include the family in the treatment planning and delivery of services for any person under the age of 18 in our system.
My question.
Is that your question?
The age, yeah.
Okay, good.
So that's why it's back there. It's also in the contract thing. And the other tabled item, I'm waiting until January. It's our finance subcommittee.
Subcommittee.
We still want it,
appointments, Yep,
you know.
okay,
but we're waiting just to, until January.
all right.
But that's So it's, I don't know how, from a procedural standpoint, it is in the contract list. You know, there are sometimes you can just approve that particular contract in old business if you wanted to, but it is listed, I believe, in our contract section today.
All right. Any other questions or discussion around old business? Seeing none, I'll move on to new business, FY 2024 November financial statement with Amy Bodville Mast. Did I say it right? Good.
Amy B.
Amy B. And the suggested motion is to approve the FY 24 November financial statement as presented. Do I have a motion?
So moved.
And now discussion. Thank you, Amy.
So, financial statement for both our mental health, fund and the millage and grant fund. Based on, some of the things we covered at the end of the fiscal year, 24, kind of adjusted some of the reporting. So for the mental health fund in particular, adjusting based on actual historical month-to-month percentages for historically, so that we're not hit at the end with a large tables cycle that kind of throws everything out. Revenues continue to be reported on a monthly basis. We're paid monthly for activities, so those will be 1/12 reported. But you'll notice with, looking at this through November, revenues, and another change, I brought the CCBHC dollars out of the Medicaid revenues, so you can kind of see how they hit. This is through November. We haven't received payments yet for October or November. So kind of, those are some of the tweaks that we've done to hopefully assist with being more proactive to identify those deficit concerns earlier. This also includes the revenue adjustment that's mentioned in the upcoming budget adjustment. So once we had our revenues, our final revenues for fiscal year 25 from the LRE, our initial budget that was passed exceeded the revenue projections. In this agenda, we'll move on to the Board of Commissioners as well. And actually, we reported it in the November meeting here, but it didn't get added to the Finance Committee, so it's the same adjustment resubmitted on this board. In general, revenues, budget to actual are a little under, and that's primarily 1.2 million of that 2 million is CCBHC specifically. The rest kind of combined, and there's some, timing issues that happen with that. So that's not a concern in general. Expenses you'll see are about $500,000 over where we might be historically based on these new projections, and we'll keep monitoring that. But that fourth column at the bottom of total expenses is kind of the number to watch as the year progresses. And then we, have the target of 10.61%. We're at 11.46, so still close, but working on those, trying to communicate as soon as possible and have that data as close to real time, and this is kind of the objective. So I don't know if there are any questions on the mental health fund. For millage, we kept it, both revenues and expenses at 1/12. That kind of flows through on a monthly basis. Our grants are paid monthly. We receive allocations from the county monthly, and it's not we're not concerned about the revenues there. There's a lot of that is matching revenues or property tax revenues. So I don't know if there are any questions on either fund or even.
Other questions? I have to say, I'm thrilled to hear you talk about solutions. It's like we can identify problems. That's fine. You're coming with a solution set as well. Do you feel like the EMR is going to help you with your reporting or the new budget software that we purchased for the county?
I think both of those together, what happens is there's a data exchange, obviously. So some of the reporting is limited that comes out of our electronic health record from a financial perspective. There are reports that were manually built and that we've been using historically, and kind of getting different information out has been challenging. So I do think we'll have a lot more flexibility, training right from the start within the EMR, and how that information translates into our general ledger, because, there's no financial payables information coming out of the electronic health record. It's only what we've billed for services. So until we actually have claims processed and paid out of the general ledger, there's that gap. And I think that
Build
just
in it.
the ease of reporting will, just the timing of getting the data out of the electronic health record will improve that whole situation. And a lot more with costing. There's a lot of costing modules that we don't have and use. So our costing process is very manual right now. So hopefully, all of those things will increase our productivity and financial.
You see some light at the, yeah.
Yes,
Yeah,
very
that's
much.
great.
Yes,
That's
very
great.
happy.
So, and then what's our billing cycle? I think you've told me that before from
But what do you mean, like
like
what?
timing wise? Cause
Are you saying
Yeah.
third-party billing?
yes,
We bill on a monthly schedule.
on a monthly schedule, but okay. So let me rephrase that or try to explain a little bit different. We tried to have like a 10-day billing cycle, meaning, bill out the door and payment received.
Yeah.
What does that look like? Is it a 30-day then?
Yeah, well, and as far as payment received, we do not have a revenue cycle timeline. We have a audit group that formed after a CARF recommendation last year for our accounts payable, or sorry, accounts receivable. And that team has been starting to develop more reporting of, what comes in and goes out. It's basically third parties are billed on a monthly schedule. It's kind of cumulative, and then they're posted when they receipt, but we don't really have a mechanism for timing all of that. So that's another advantage.
Yeah, it could be
The
helpful.
whole-
Yeah,
Yeah.
yeah.
Accounts receivable would be very, that's something that we're really looking forward to, just seeing what's out available and the automation of it,
Exactly.
because so much of it's me.
I'm excited. I'm excited for you too.
Yeah.
So, all right, so I'll keep you up here too, but the motion on the table right now is to approve the FY 2024 November financial statement as presented. We'll do a roll call vote. Oh, bathroom break.
Yes. Yes.
Yes.
Yes.
Yes.
Yes.
Yes. Motion passes. Next up is the FY 25 LRE revenue reduction. Suggested motion is to approve the BA1 FY 2025 LRE revenue reduction as presented. Do I have a motion?
So
Moved. Support.
Support. All right, in discussion?
And just to reiterate, this is the same one. It's to align our revenues with the actual final projections that we received from the LRE.
Okay.
What if we don't approve it?
That's a good question.
Oh,
Will we get paid?
we probably would. That's an interesting question.
Mm-hmm.
Can we approve it under duress?
Yeah. Approval with instructions. Determine if the actual revenue that we're projecting is sufficient to cover the true cost of care. So you could say, yeah, we'll accept this document, so that whatever, but you could say,
And that could be done by amendment to the motion.
Yes.
So.
Mhm.
Just a motion to approve under duress.
well, I would recommend something like this, approval with the request that the CEO work with the region to determine the necessary amount of Medicaid that's needed to cover anticipated Medicaid expenditures.
Actual expenditure.
Yeah,
Yeah.
yeah, and anticipated too, like, projected. You could do that, and the board would be giving me a directive that accepting this is contingent on truly understanding that we complete an analysis to determine if the Medicaid revenue is sufficient to serve Medicaid recipients under the contract. That makes sense. And so that launches what I'm already doing, gives it more teeth in a sense.
I move an amendment to the motion to that effect. However, you can codify that.
I'm
And
trying.
Do I have a second? I'm trying to.
Second.
Second. All right. And so CEO to
I-
work with, you've got it?
Kind of.
To request that the CEO work with the region to determine if Medicaid revenue is sufficient to serve Medicaid recipients. Does
Yeah.
that suffice?
She's written it down, Amanda, so you can use it
Yeah.
for notes.
And
Okay.
it just allows me to say to the region, by the way, I've been directed to determine if the
Okay.
amount of revenue is actually
Yeah.
adequate
As
to
presented,
meet the Medicaid need.
Mhm.
as
That's what we want from
presented
here.
with
Right.
Yeah.
the request that the CEO work with the region or
Yeah,
LER?
Make sure a regional entity.
A regional entity. Okay,
LRE.
so,
I do too.
Thanks, Tom. Okay, I'll get that to her.
okay, so we've amended the motion to include now to approve the BA1 FY 2025 LRA revenue reduction as presented with a request that the CEO work with the region to determine Medicaid revenue, if Medicaid revenue is sufficient to serve the Medicaid recipients. So, and we will get that to you, Amanda. That's what we're going to vote on. All right. So we'll go to a roll call vote.
Yes.
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 Yes. And the motion passes. I like that. Gives you a little teeth too, when you go
Yep.
forward.
Makes me accountable to this board to to bring that report forward.
We feel
Absolutely.
Dang darn it.
better.
Know the answer, but we'll validate the answer.
Some teeth from your board to
Yeah.
go back to the LRE and
Yeah,
say, hey,
and
let's,
they always have somebody watch us. So LRE, if you're
yep,
listening,
there you go.
it's just our partnership. Just figuring it out.
It's a good partnership.
Yeah.
All right. So BA2 is Community Foundation grants for CIT response vehicle, which I'm wondering if we used a lot of this last quarter. The suggested motion is to approve the BA2 Community Foundation grants for the CIT response vehicle as presented. Do I have a motion?
So moved.
Second.
In discussion? All the diversions from the hospital, was that the CIT?
Yeah, but they ride along with law enforcement.
Yeah.
And so we found some way to get a grant to get a vehicle for them in addition to ride-alongs and other things with them. This was in the paper as one of the very successful programs in the county. And we're happy to been able to leverage grants and other funds to get another vehicle to help with that whole process.
Even like with your percentage of diversions that you presented, I mean, even, is there a dollar amount you could potentially
Yeah.
subjectively kind of associate with
Yeah,
that? 'Cause
absolutely.
That's impactful
Yeah,
as
If,
well.
if the logic is every one of these diversions diverted a hospitalization and
Right,
finding.
you can average out your hospitalizations and give that number.
Taking out crisis context that really wasn't a hospitalization one in the first place.
Mhm.
But
Exactly.
Yeah, there's a way for us to quantify and to talk about savings, but anytime you do that, I want to make sure all the variables are accurate, because sometimes people will make us correlations like, this program prevented that, and it's like, well, no, eating broccoli would have done the same exact thing. So you have to kind of be careful when you're making those associations, but we can do that.
I think it'd give you something to celebrate.
Oh, yeah.
Truly.
We
And
got a lot of that good
congratulations
stuff.
to your team too for the results. So is there other discussion regarding this item? It's great to see it come to fruition.
Mhm.
All right, so we'll go to a roll call vote, and the motion is to approve the BHU Community Foundation grant for CIT response vehicle as presented.
Yes.
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 Yes. And the motion passes. Amy, I think we get to say goodbye. Merry Christmas. Happy holidays. Yeah. So next on the agenda is the December 2024 amended and renewed services contract. And that's attachment D with Dr. Michael Brashears.
Did
I
we
miss
do the
something?
LRE FSR attachment D? But that's just for our
Information only, the FSR,
Sorry.
Yeah. Oh,
kind of like revenue pending.
might have been an ad. Yeah. So, okay. It must have been an ad from when I printed yesterday.
Yeah, I'm just
Sorry.
organizing my packet real quick. I did the staple fell out, so now I'm looking for. No, I think I'll be able.
I'll have to tell you what my process is because I write everything down before I come in. So I usually print the day before to do it. So if there are edits, I won't have them. So, but thank you. All right. So where was I? December 2024 amended and renewed services contract with Dr. Michael Brashears. Suggested motion is to approve the amended and the renewed December 2024 service contracts as presented. Do I have a motion
So moved.
Support.
and discussion?
So these are all amendments or renewals of existing contracts. I mentioned in my lengthy CEO report
Mhm.
that we had two for, one for Holland Hospital and one for Robert Brown to increase the scope of that contract. Those are listed there. And just make sure I understand, where am I? Yeah. Then we have some of them, like look, number 7 on the list, that's to increase our psychiatric diagnostic evaluations when we need second opinions for hospitalization. And I will let you know that Dr. Swart has done this for us for years, and he charges us next to nothing to do this service. And so when you look at the kind of utilization that we have to have by law, second opinion by a psychologist for involuntary hospitalizations and things like that. And he serves that purpose for us. He's on call. It works great. The locum tenens is our psychiatry. So we have to use a kind of like a staffing agency to staff our psychiatry primarily as we look to recruit and retain Ottawa County employees. So that keeps that contract in place, and it usually has a very hefty dollar amount we have, but we don't utilize all of it. But we're in the process of hiring our own nurse practitioners and psychiatrists to replace this eventually, but the whole state has a psychiatrist shortage. And so that's what that pays for.
I might have,
You might have somebody good.
I have
send 'em around.
somebody for you too.
Yeah.
So.
And so then there's a renewal of the Arc of Michigan to help do with some independent facilitation services they provide for us. So these are all existing contracts that we've already had and have approval in the past for that are up for renewal or amendment. And I can take any questions on those.
One question that I have is on the Holland Community Hospital one. So is the 1.3 million the current then contracted amount, or is that what what it has added up to? I know,
Let's see here.
under the budgeted amount.
Oh, it's up to, Yeah, that's up to it, of that amount, and
Okay.
it's our whole inpatient budget, all of these are thrown in together. But it's up to that amount. It does assume an increase to the specific provider, but within the context of our overall inpatient budget. So I'm saying it has to stay within, all expenses within our inpatient budget line as a whole.
Okay.
And this is what it could probably do up to if it's maximized, because we know what the daily rate is.
Okay.
So that's up to that actual contractual amount, but it's not an additional expenditure in my mind, because it's in the same bucket as inpatient hospitalization. And I'm assuming there'll be reductions in other providers to offset this increase to this provider.
Okay.
How might we see in the budget system, the utilization of this?
Yeah. Oh, yeah. So
What'll it look like?
yeah, so we'll be able to demonstrate utilization on a daily and monthly and quarterly use and compare that to the entire inpatient budget and to look to see if it's had an impact on it. That's one measure to do it. But we already keep track, number of authorized days, number of admissions, the type of individuals in terms of diagnostic criteria that are being hospitalized, length of stay. Dave, how long on average are people in? And so we'll take those metrics and superimpose that on this contract to see, did it actually improve things, or do we just buy 4 beds all the time?
Right.
You know,
Right.
and we've agreed as partners that we'll look at this quarterly and every 6 months to see how it's working. But we'll bring to the board a more robust inpatient hospitalization kind of report, so you can see all the variables that we track. Length of stay being very important, how long someone stays, readmission rates. To me, it's called recidivism if they have to go back into the hospital within 30 days of discharge.
It won't be
So if someone's discharged from the hospital, and they go back in 30 days, something went awry, or they needed more time. So we keep track of recidivism rates as well.
Something to think of too. So we're guaranteeing $904 a day.
Mhm.
Is that, and it's okay per bed. What we do, so that's guaranteed staffing, basically.
Yes,
There
it
may
helps
be
that.
other things that we can ask that they do on the days that you don't have all 4 beds filled.
Yes.
Does that
And-
make sense?
Yeah. So what do you do when there's a
What do you
bad
do with
day?
that staff? You're paying staff.
Right. So they may adjust some of their expenditures, but if they
Flex,
do,
yeah.
then
Can
we
they
should
flex
see the
down or
benefit
go
of
on
that.
call? Yeah.
But I will tell you, I'm not anticipating a lot of days of empty beds. We average almost 1 hospitalization a day.
Okay.
I'm thinking this is like, there's a whole clog system. This just gives us choice of
Relief.
first utilization over
Yeah.
everybody else standing in line, waiting to
I
get in.
love the idea. I love the idea.
And it helps them because they like our partnership and we work well together.
Yep.
You know, they're getting requests from all over the state to have people transferred in.
Oh,
We're
absolutely.
competing with
Yeah.
Detroit.
Well, in North Ottawa, oftentimes we have people waiting their days on end trying to
Mhm.
find, a bed. So, yeah, even maybe communication that direction. Maybe it's improved in 10 years. I'm sure it has. So, all right. So do we want to take, you've kind of addressed both of these things, but the motion on the table is to approve the amended and renewed December 2024 service contracts as presented. So
Right.
we'll go roll call. Vote.
Yes.
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 Yes. Motion passes. And next on the agenda for action items is the December 2024 new service contracts, attachment E with Dr. Michael Bashirs to approve the new December 2024 service contracts as presented. Do I have a motion?
I'll move.
Is there further discussion?
Yeah, so to the board's attention, of the 7 new contracts, 2 of them, only 2 of them impact the Medicaid funding stream. We are in a Medicaid projected deficit, so we have to be careful that we don't just improve additional expenditures. The 2 that have the Medicaid expenditures on it One is Keys to Happiness for the counseling, which I discussed in old business. And the other one is for diabetes training sessions to our contract agency staff and our staff to help us monitor some the variables associated with diabetes. And you can see it's 4 trainings a year. It's not a huge impact to it. So those 2 are the only Medicaid-specific funding sources. The rest are through grants. We have some outreach that we're doing with our System of Care grant to help beef up our integration and utilization in the Latino community. So you see 2 of those. Those are requirements by the grant that you look at certain populations and make sure that you have Spanish-speaking folks and other services for that. That's part of the System of Care grant, and you kind of see some of the specific things there. So those are by design focused to those groups. It wasn't like we just one day decided we should do this. This is a requirement. We should be doing that. And it's paid through the System of Care grant money. Then you have some things that are related to CCBHC expenditures. One's called Zero Suicide. This is an evidence-based practice that we're mandated to use because of CCBHC. So we have to have staff that are trained in understanding the evidence-based practice of zero suicide, which suggests that you could limit, not eliminate, that you could limit the negative result of suicide through a series of interventions and case management strategies and working together. So part of the CCBHC funds that we get pay for that evidence-based practice to be delivered. And, you know, as someone that has a loved one that lost their life to suicide, I don't really like the name of the thing, to be honest with you, but I can't really change that. Because no matter what families do, sometimes suicides happen. No matter what the community does, it can occur. But we should have the goal to try to eliminate that occurrence as much as we can. But I will say for us that are in this community, that are survivors of that, it's like saying zero cancer. We all want that.
Right.
But I don't want the community, the board, to think that there's a method that can fundamentally eliminate all suicides. That is not the intent here, but I've been very careful in talking about it because I have got feedback from community members about what does this mean? And my loved one, what did we do something wrong? Did the system fail? So just a little, that's the name of the evidence-based practice. It's not suggesting that. It shows a lot of efficacy in decreasing the rate of completed suicides. But it's a case management collaborative process. And I could take any questions on any of the other ones, but you know, just there's only 2 on here that are Medicaid. So as we're dealing with this Medicaid issue, every new contract that has Medicaid funding in it, I'm scrutinizing to determine, can we live without it for a moment or do we need it? Same way with our direct operated staff.
Decision-making paradigm, yeah.
Yep.
Discussion?
You know, I just had a question on that grant, that System of Care. It says that the grantee has the responsibilities to collect and report data on the program outcomes and services.
Yes.
Who does that go to?
Us,
Okay,
yes.
so there is that data on that.
Yeah, and you know, and when we get our outcomes dashboard out, we can add elements.
Right,
You know, to me, it's like, do these things make a difference or not?
yeah, exactly.
You know, because if not, I mean, they're great to have. Who's against, you know, that? But do they move the needle?
Right.
But yeah, with you're going to hear this a lot, with auto being installed, a lot of this will come. So once it's installed, we'll be like, oh, it didn't do everything, but it did a lot of things, right? So we still have to construct other ways of communicating actual outcomes to the things that we got grants to do. So if it didn't improve the quality of life for somebody or change what it was supposed to, then if you renew it or have it,
Right,
should be part of the consideration.
thank you.
Any further discussion? All right, seeing none. So the motion is to approve the new December 2024 service contracts as presented. Do a roll call vote?
Yes.
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 Yes. Yes. And the motion passes. It looks like under number 11, general information, comments and meetings attended, we have nothing.
Should we do the, one more? Yeah. Oh,
On.
Yeah.
No, I don't have it, but okay, here we go. All right. These are some edits, so. All right, and so this is the service contracts, December 24 new. Okay, 2025 CMHOC board meeting schedule, see attached. The suggested motion is to approve the 2025 CMHOC board meeting schedule as presented. Do I have a motion
I have a quick, the last date should be 2025 on there.
as amended?
Oh, yeah.
December 19th.
Yeah.
We did it yesterday too. Feels like, it, right?
Right. So, yeah, no, what I do is I print these like the night
Yeah.
before, yeah.
Yeah,
I
we had
did
a,
it
we had a
yesterday,
change.
so,
We had a late
okay.
change too.
So that's why I don't have this one on here. So do we want to, can we say as presented now that we just wrote 2025 down there? Is that okay? As presented. Thank you for the catch. All right, do I have a motion?
So moved.
Second.
Second. Is there any discussion? From the fourth Friday
To the third.
to the third, yeah, so November and December.
Okay.
Yep. Thank you for bringing that forward. I know we've made adjustments as we, like this meeting, for instance, I've adjusted as well.
Right.
So. All right.
That way we can get it, the public can see it.
Okay. So the motion is to approve the 2025 CMHOC board meeting schedule as presented. We'll go to all those in favor, say aye.
Aye.
And opposed, same sign. Motion passes. All right, now general information, comments and meetings attended, which nothing is there. And we are up to public comments, number 2.
Barbara Lee Van Horsen from the City of Grand Haven and the Momentum Center. I thank you for your commitment and dedication to providing adequate services. I do want to say that stigma is alive and well, and stigma results in lower prioritization of public resources that are allocated to mental health service. And that results in poor quality of care being delivered to people in need. I'd like to put this in a little bit of context because it isn't just about our state. In the 1840s, Dorothea Dix really pushed to address the inhumane treatment that people with mental illness were receiving because of the stigmatization. She was successful in lobbying the country, the US government, to build 32 state psychiatric hospitals. And the outpouring of that was a great relief and gratitude from family members and community members who finally felt that there were people who could adequately care for their loved ones. But those facilities were never adequately funded. And as a result, there ended up being human abuses, human right violations. And that led to a real push to move people out of those institutions, especially with the advent of antipsychotic drugs in the 1950s. There became a real high push to get people out of those hospitals and into community care. In 1963, President John F. Kennedy signed the Community Mental Health Act. That's what changed admission criteria, so you couldn't admit somebody to a psychiatric hospital unless they posed a danger to themselves or somebody else. And it was supposed to provide funding for community-based preventative care and treatment facilities. But between the war and the economic crisis, that program was never adequately funded. In 1965, Medicaid passed, but it excluded coverage for people in institutions for mental diseases. That meant that states had a great big incentive for moving people out of those hospitals and into nursing homes and general hospitals. In 1980, President Jimmy Carter signed the Mental Health Systems Act, which was supposed to lead to a restructuring of the community health systems and improve services. But in 1981, under the Omnibus Budget Reconciliation Act, President Ronald Reagan repealed that legislation and instead established block grants for states. That officially ended the federal government's role in providing any funding for mental health services. It was a final step in deinstitutionalization, and in the process, the federal government cut mental health service funding by 30%. In the aftermath of the Great Recession of 2009, states were forced to cut an additional $4.35 billion in public mental health spending over 3 years. That was the largest funding since, decrease in funding since deinstitutionalization. So in 2010, there were only 43,000 psychiatric beds in the United States, 14 beds for every 100,000 people. The same ratio in 1850 when Dorothea Dick was lobbying for care. And these numbers, this is the history of our country's approach to mental health. And we do need to get creative, and we do need to figure out grassroots solutions, and we do need to advocate and push these needs up and up and up, because traditionally this country doesn't care for the people that need that care. Stigma leads to reduced public resources. And I agree that what we receive is not enough, but just saying it's not enough isn't going to magically produce the resources themselves. The states aren't holding on to a whole bunch of money that they're refusing to give to the LRE, and the LRE is not holding on to a whole bunch of money they're refusing to give to Ottawa County. This is a huge issue throughout our entire system. So I really do urge you all to continue to be advocates at every step of our healthcare system, of our political system. And I want to remind you too that those creative solutions, things like the CIT does reduce costs. Things like the social recreational program, every dollar we receive from that millage money creates a $4 return on investment. That's not money that's coming back in, it's slots that are being opened. $1 million worth of care the CMH is allowed to provide to people because members are getting better while needing less costly intervention. So we all need to be creative. We all need to work together. Mental health is a need. Stigma is real. We can all be part of that solution. Thank you.
That's fantastic. Thank you, Barbara.
Rosalie Austin, City of Holland. With the institutionalization, the money definitely did not follow the person. So, public mental health system also serves individuals with intellectual and developmental disabilities, and their care is costly also. And there's even less available beds for them. And hopefully Holland Hospital can be trained, more receptive to serving that population locally, so they don't have to go out of county and out of state. That's even more costly and traumatizing. And we didn't talk about the Earned Sick Time Act.
Oh, yeah.
That's gonna come in effect February, I think. But that's gonna affect self-directed providers. We'll have to pay.
Gonna have to pay earned sick time.
I mean, it's good. I'm glad we'll be able to offer it, but it is a mandate, an unfunded mandate at this point, or where's the money gonna come for that? And yeah,
Very informative. I used to take my nursing students to Independence, Iowa, where there was still where there are 2 active I hate to call them institutions because it was really, they were homes. The people were born there and died there, literally agrarian, self-sustaining. It was really quite beautiful, but like you said, Barbara, not enough staff leads to really bad outcomes too. So thank you for bringing me back, kind of a flashback of my past. I appreciate that. But there are big solutions out there. We do need to collaborate to find out how we can innovate with what we have in our resources and do something for our community. So with that said, This meeting is adjourned. Merry Christmas and Happy New Year to all of you. And thank you for all your hard work.
You.
Amanda, I have new contact information I want to give you.